Good day, and welcome to the second round of 4th Grand Clinico-Pathology Conference of Customized March Batch School Year 2020-2021 of JONELTA Foundation School of Medicine, University Perpetual Health DALTA System for the third-year medical students. I'm Dr. Rodalia Nicolas, and with me is Dr. Zita de la Merced, your host for this activity. And to start off, may we listen to the Philippine and Indian national anthems, followed by prayer and the university's mission and vision.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Mission. The JONELTA Foundation School of Medicine is dedicated to developing a professionally competent and holistic healer, socially responsive to the needs of humanity, and imbued with moral, ethical, and spiritual values. Vision. The JONELTA Foundation School of Medicine, believing that Christian character building through quality education is nation building, aspires to be an outstanding center of excellence in medical education, training, research, and community service, committed to the achievement of the highest quality of life. Goals: to develop the complete physician instilled with values geared towards health promotion and community service. To enhance the faculty development through sustained and relevant learning programs cascaded to the student tree. To contribute to the upliftment of the community through relevant and viable health services. To promote research and appropriate medical services with significant impact to society. Let us pray. Loving Heavenly Father, we come to you this hour asking for your blessing and help as we are gathered together. We pray for your guidance in the matters at hand and ask that you would clearly show us how to conduct our work with a spirit of joy and enthusiasm. Give us the desire to find ways to excel in our work. Help us to work together and encourage each other to excellence. We ask that we would challenge each other to reach higher and farther to be the best we can be. We ask this in the name of the Lord Jesus Christ. Amen.
To continue with our activities, I deem to have a great honor and privilege to introduce the President of the University of Perpetual Health DALTA, Mr. Anthony Jose M. Tamayo, and our School Director, Dr. Arnaldo S. de Guzman, to deliver their inspiring messages.
To our School Director, Dr. Arnaldo S. de Guzman, to our Dean of the College of Medicine, Dr. Emelita M. Gatmaitan, other officials of the Faculty of Pathology, faculty members, students, friends, fellow Perpetualites, good morning. I would like to extend my cordial greetings to all the participants of the College of Medicine's 4th Annual Grand Clinico-Pathologic Conference. Congratulations to the Faculty of Pathology for organizing this event, which will serve as a great medical educational tool for our students. This conference will give our future physicians the opportunity to enhance their clinical problem-solving skills to become professionally competent and holistic healers. Despite the challenges of this pandemic, I truly appreciate your efforts and creativity to conduct this much-awaited event. In the past 25 years, the JONELTA Foundation School of Medicine has attained various awards and recognitions locally and internationally. We have produced board top-notchers as well as more than 1,500 graduates and earned 100% passing rate in the physician licensure exam. And now, as we have opened our doors to international students, the College of Medicine strives even more in providing the best training to our future physicians. I do hope that our international students have already considered our university as your second home. The mixture of language and culture in this institution will make academic learning even more vibrant and meaningful. Finally, I hope that all our participants will have a very productive conference today. I would also like to congratulate all the winners of this academic competition. May this activity serve as a great training ground to our future doctors who are compassionate and competent to help people achieve healthy lives. May God bless us all and always stay safe.
A blessed morning to all. I am once again delighted to be with you as you continue with the Grand Clinico-Pathologic Conference with much positivity, new mindset, new paradigms, and renewed hope. In this conference, we are invited to reflect once again on the beauty of your profession. My beloved future doctors, you hold the profession that should be held in high consideration. Why? It is because the good that it intends to protect, the good of human life, is a highly precious one. Life is the time that is granted to us to express concretely the potential riches which each of us bears and to make our contribution to the common progress of mankind. Life is a time that is given to us to embody in ourselves and in history the values of love, goodness, joy, justice, and peace to which the human heart aspires. Saint Pope John Paul II tells us that life, therefore, is a precious good in its entirety and in every part of it. And those who spend their energies to defend it, to restore it, and to promote its full development, acquire the right to the gratitude of every fellow creature of theirs. On the contrary, those who dare to attack it in any way stain themselves with a serious crime and incur the severe condemnation of that judge against which there is no appeal, conscience, the mirror of God. It is our hope in this occasion that anyone who chooses to put himself in the service of human life will feel vibrating in him pride in belonging to a profession whose members throughout the centuries have offered luminous testimonies of generous humanitarianism, teaching, in some cases, the supreme heroism of self-sacrifice to save their brother. Finally, allow me to invite everyone to thank God once again and always for the gift of good health. We ask Him to bless every member of our families and to bless our Perpetualite family. May we hurdle this year with flying colors and emerge victorious amidst the uncertainties and challenges of this pandemic. Congratulations to everyone, and may our Mother of Perpetual Help, our patroness, be our guide and inspiration. Thank you again, and together we say, we love Perpetual.
We would like to thank our University President, Mr. Anthony Jose M. Tamayo, and School Director, Dr. Arnaldo de Guzman, for a very profound and inspiring messages. Once again, thank you, sirs. In addition, to properly welcome you to this event, we would like to hear a welcome remark and to give us a short background of this annual activity of the Department of Pathology from our very own Deputy Chair of the Department, Dr. David Brian Olveda.
Good day to all. I hope these opening remarks find you well and happy. How does one arrive at a correct diagnosis? The process is not straightforward. It's like sculpting a human statue. It's easy to think what to put on that statue, like the kind of eyes, nose, or other features. But an artist once said, to make a masterpiece, like the statue of David, one must remove everything that is not David. Likewise, do not focus on your diagnosis. Instead, focus on everything that is not that diagnosis and chisel it away. Chip away the errors of reasoning and a clear path will follow, hopefully to a much better diagnosis. Our future doctors must realize that no matter how good they are, they may not get the correct diagnosis. They can only make steps in not making an incorrect one. I believe this thought process is the true heart of a CPC. Welcome to our CPC. We are proud to present the 4 houses: Muggles, Ivermorny, Durmstrang, and Voldemort. Let this CPC be our chisel. Good luck.
Thank you, Dr. Olveda, for giving us insight on what this activity is all about. This activity will not be possible without the help of the entire faculty. It is a pleasure to present to you each faculty member.
We now proceed to the introduction of our panel of judges. Our first judge is Denise Lister from the University of the Philippines, a graduate of Bachelor of Science in Biology in 2010. She is an academic scholar at the University of the East Ramon Magsaysay Medical Center, where she obtained her medical degree in 2014. Following her graduation, she had her postgraduate internship at the Department of Health, Philippine Centers for Specialized Healthcare. She then had her residency training in anatomic and clinical pathology at Quirino Memorial Medical Center from 2016 to 2019. During her residency training, she topped the yearly in-service examination both in anatomic and clinical pathology. She is also affiliated with different organizations and had her several research papers. She is the current head of the Molecular Laboratory of Quirino Memorial Medical Center. Let us welcome my colleague, Dr. Angelica Maris S. Caindec. Our second judge is a graduate of BS Biology at the University of Santo Tomas in 1998, a nursing graduate at the Philippine College of Health Sciences in 2005, and had her master's in nursing in the same institution. She obtained her medical degree at the DALTA University and pursued internal medicine residency training at Mary Johnston Hospital. She also had her fellowship diploma in pain management at London Academy of Sports and Health Sciences. Doctors, let us all welcome Dr. Rosny Briones Ruiz.
Introducing our third judge, she is a fellow of Philippine Society of Pathologists with degree in Bachelor of Science and Medical Technology and Doctor of Medicine at the University of Santo Tomas. She had her residency training in anatomic and clinical pathology at the Medical City and topped the yearly in-service exam in both disciplines. In 2014, she had her training in breast pathology at Northwestern University, USA. Furthermore, in 2015, she represented the Philippines as a travel scholar for biosafety and biosecurity training by U.S. Department of State and CDRF Global. She is also an active faculty member of San Beda College of Medicine and Ateneo School of Public Health. At present, she is the chair of the Pathology Department of Pasig City Children's Hospital, a COVID-19 referral center, and Pasig Molecular Laboratory. She is also the chair of Department of Pathology and Laboratories of Medical Center Manila, and a Laboratory Quality Assurance Consultant Director of the Medical City, both in Ortigas and Clark, Pampanga. Doctors, let us all welcome Dr. Sarah Jane Tatay Lim. Our fourth judge is a diplomate in internal medicine. She took her Bachelor of Science in Nursing at University of Santo Tomas and pursued her Doctor of Medicine at Our Lady of Fatima University. She had her residency training in internal medicine at Fatima Medical Center and had her advanced course in diabetes education and care at the Institute for Studies on Diabetes Foundation Incorporation. She completed her Master in Hospital Administration at Philippine Christian University. At present, she is the Chief of Clinics of Caloocan City North Medical Center and a Medical Officer at Caloocan City Anti-Drug Abuse Council. Let us all welcome Dr. Cybel A. Nam.
Before we move on further, I would like to present the Grand CPC guidelines. Criteria for judging: graphics and video content and layout, 20%, presentation skills, 20%, master of the case and flow of the case discussion, 20%, ability to answer the judge's question, 20%, scores in the MCQ, 20%, for a total of 100%. Now we proceed to the first part of the competition, which is the video presentation, followed by question and answer portion with assigned judges. Each house will have a minimum of 5 presenters. These presenters are pre-selected by the houses among its members. Note that only 5 presenters are allowed to participate in the Q&A activity. The rest of the members of each houses and their respective mentors are kept out from the activity. Each judge is assigned with one house to question and can direct the question to a specific presenter or to any members of the group. Each presenter should be prepared to answer, since the grade of one presenter will be the same for all members of the group. Each group or house is given a maximum of 10 minutes to discuss the case. Note that each minute in excess of the given time, 1 point will be deducted from the group.
The order of presentation of houses is randomly pre-drawn and as follows. The first group to present is Muggles, judged by Dr. Angelica Maris Caindic. This group is mentored by Dr. Dina Razad Miranda and Dr. Jennifer Mateo, together with our guest mentor from the Department of ENT, Dr. Katrina Ann Balmores.
Let's first take a look at the patient's details. Our patient is a 27-year-old West African professional footballer who presents with a chief complaint of shortness of breath. 3 days prior to the consult, he experienced non-radiating abdominal pain in the late afternoon, which was relieved by antacids. 2 hours prior to the consult, he experienced a syncopal episode while teaching football and was brought to the hospital by his peers. The patient has a past medical history of a right bundle branch block, which was noted on an ECG taken 2 months ago as a part of routine annual physical exam for the footballers. The patient is athletic, a non-smoker, but occasionally consumes alcohol. He has a family history of gastric ulcer, leukemia, liver disease, and sudden unexplained death syndrome. The review of systems is positive for dyspnea and abdominal pain. Physical examination findings show that our patient has increased blood pressure at the emergency room, is tachycardic, tachypneic, with increased breath sounds on both lung field and no wheezes, rales, or murmurs. The salient findings are as follows. And the initial impression in this case is an acute myocardial infarction. Summary of course in the ward. The patient was hooked to the oxygen. CBC, blood chemistry, chest X-ray, ECG were requested. Blood chemistry and immunology findings are normal and unremarkable. In leads V1 and V2, a J point elevation of greater than 2 mm with chord ST T segment elevation, followed by a negative T wave is seen.
Here are the differentials considered in this patient. Let's go through it one by one. Acute myocardial infarction is ruled in because of the syncope, dyspnea, abdominal pain, increased blood pressure at the ER, tachycardia, arrhythmia, and a family history of sudden death. It is ruled out as there is no nausea, vomiting, no radiating pain, no squeezing or crushing chest pain, no chest tightness, no fatigue or diaphoresis. Hypertrophic cardiomyopathy is considered because of the syncope, dyspnea, arrhythmia, and the fact that he's a young athlete with a family history of sudden death. However, it is ruled out as there is no edema of the extremities, no chest pain, no heart murmurs, and no crackles. A third differential of abdominal aortic dissection is ruled in due to the syncope, dyspnea, abdominal pain, increased blood pressure at the ER, tachycardia, and arrhythmia. It is ruled out as there is no sudden onset severe chest pain, no radiating pain, no heart murmurs or diaphoresis. A final differential of acute pancreatitis is ruled in because of the dyspnea, abdominal pain, tachycardia, and a history of alcohol consumption since the age of 22. It is ruled out as there is no fever, no nausea or vomiting, no radiating pain, and most importantly, the serum liver enzymes are normal. And now, to reveal a final diagnosis. Draconiforce!
The final diagnosis for this patient is Brugada syndrome. The clinical basis is as follows. The patient is a young male of about 27 years old. He has a family history of sudden unexplained death. And there was right bundle branch block noted on prior ECG taken 2 months prior to consultation. Tachycardia was also noted. Other related findings seen in the consult are tachypnea, increased blood pressure, an episode of syncope, and most importantly ECG tracings with ST elevation along V1 to V2, that is Brugada sign, was noted. Summary of course in the ward. Admission was advised, but the patient opted to go home against medical advice. 24 hours post home against medical advice, patient resumed drinking. He fell asleep and was moaning, gasping for breath. Eventually found to be not breathing at all. Patient was rushed to the ER again. On palpation was found to be pulseless. CPR was initiated, eventually pronounced dead at the ER.
Pathophysiology. A 27-year-old male professional athlete with a family history of sudden unexplained death syndrome in the brother and a right bundle branch block noted on the ECG 2 months prior to consult. As per our discussion, we came to a final diagnosis of Brugada syndrome. In Brugada syndrome, there are alterations in the SCN5A gene which code for the cardiac sodium channels. These faulty sodium channels lead to alterations in the ventricular depolarization and contractility. Therefore, there is compromised blood flow to the brain, which explains why the patient experienced syncope. The decreased blood flow to the respiratory musculature is also there and explains our chief complaint, which is dyspnea. In the ER, the patient was provided with oxygen. This led to an increase in oxygen supply to the brain and respiratory musculature. Therefore, prompt symptom alleviation was seen. 24 hours post home against medical advice, the patient had an alcohol drinking session followed by sleep. Alcohol has an inhibitory effect on cardiac sodium channel gating, which further aggravated his symptoms and acted as a trigger. During sleep, our resting heart rate drops and there is a decrease in oxygen levels. All of this led to the patient going into cardiorespiratory distress, which explains why he was moaning during sleep and there was pulselessness on palpation. This led to multi-organ failure and ventricular fibrillation, and the patient ultimately died. Cause of death: immediate cause ventricular arrhythmia, antecedent cause cardiac arrest, underlying cause Brugada syndrome, other contributing factors family history of sudden unexplained death syndrome.
So what is Brugada syndrome? Brugada syndrome is a channelopathy associated with a sodium channel gene mutation SCN5A on chromosome 3p21. Type 1 ECG pattern as seen in our patient is linked to a high risk of sudden death. It has been called by various names including sleep death in the Laos and to rise and moan in sleep in the Philippines. A characteristic ECG pattern includes right bundle branch block with ST segment elevation in the right chest slits V1 to V3. The clinical criteria for the diagnosis of Brugada syndrome are data from the family history like sudden cardiac death in a family member younger than 45 years old and ECG type 1 in family members. Then arrhythmia related symptoms like syncope, seizures and nocturnal agonal respiration. And finally, documented ventricular arrhythmias like polymorphic ventricular tachycardia and ventricular fibrillation. Criteria for the definitive diagnosis of Brugada syndrome are a type 1 ECG either elicited spontaneously or by class 1 antiarrhythmic drugs and at least one of the above mentioned clinical criteria.
Currently, the only proven management for Brugada syndrome which can prevent sudden cardiac death is the use of an implantable cardioverter defibrillator or an ICD. The goal of ICD here to detect and treat any life-threatening tachyarrhythmia but not to prevent them. EP-guided antiarrhythmic therapy with class 1A antiarrhythmic drug can be used to prevent arrhythmias rather than terminate them after they occur. Procainamide is contraindicated because of its effect to unmask the Brugada syndrome and induce arrhythmogenesis like class 1C. Empirical quinidine therapy can be used for asymptomatic Brugada syndrome patients. If an ICD doesn't effectively and safely control Brugada syndrome symptoms, radiofrequency catheter ablation may be used. The catheter delivers high energy that scar or destroy the heart tissue responsible for the abnormal heart rhythm. Recommendation and advice for Brugada syndrome patients follow. If with the family history of sudden unexplained death syndrome is present, suggest genetic testing among other members of the family. Patient with ECG pattern such as right bundle branch block should be monitored and be encouraged to treat it aggressively. Contact the cardiologist immediately in case of presenting syncope, seizure or nocturnal agonal respiration. Regular follow-up to identify the development of symptoms, genetic testing to support the clinical diagnosis.
So, congratulations, Libby, for delivering a well-made and comprehensive discussion of the case. So, for my first question, you included aortic dissection in part of your differential diagnosis, right? So, what is the typical patient profile and associated comorbidities or conditions that you would associate with aortic dissection? Anyone can answer.
Dr. Myself Sayyid Alam, like in aortic dissection, especially we see patient with Marfan syndrome and related to collagen diseases, Marfan syndrome, Ehlers-Danlos syndrome, like collagen, there will be a collagen defects patient with aortic dissection. And also in this patient was like he was drinking and all, we can assume that's why we chose that.
Okay, that's good. Aside from Marfan's and other collagen disorders that you mentioned, what other comorbidities would you associate with aortic dissection, especially in an elderly patient? Would you like to move on to the second question? Okay. Aside from aortic dissection, you also included acute pancreatitis in your list of differentials. So if you were able to see the patient in the emergency room, what in the history would you be asking the patient with regards to the character of the abdominal pain, and what maneuvers can you do on the patient that would alleviate and aggravate the abdominal pain?
Doctor, we can if you want to know like how severe, like in acute pancreatitis, the pain is very severe when the patient present, And also if we can check some signs like if you want to light press or deep press, that can alleviate it.
Okay. It's good. So aside from the laboratory tests that were done on the patient, what other diagnostics and lab workup would you be requesting on the patient?
Doctor,
Or are you
for
satisfied? Okay, continue.
Doctor, for the Brugada syndrome or for acute pancreatitis?
It's for
Brugada.
if you were attending at the ER, if you were considering all your differentials in Brugada syndrome, so what other tests would you be requesting for?
Doctor, we can do an echo to rule out any structural heart abnormalities. So echocardiogram could be one of them.
And doctor, the like most important thing we can do, as I like, if patient is present as a asymptomatic, we can do this stress testing, which can we can see like what are the changes comes after the stress test in ECG. We can which can help in Brugada syndrome, because Brugada is very rare disease and it's very hard to find proper cause and like proper problem in this Brugada. So we can do stress testing, which is very, very important.
Any other lab workups you'd like to request for? Lab tests?
Yes, for Dr. Since we're also considering the differential of acute pancreatitis, but we would request
Ritesh, I can't hear your audio. Sorry. Can you repeat that? Your answer.
Can I? Are you able to hear me now?
Yes.
Saying that since we're considering a differential of acute pancreatitis, but we would also request for the liver enzymes, your AST and ALT, and also your serum LDH glycemic index. We would be considering the Ranson's criteria, and your lipase and amylase, if within normal, would help us to rule out pancreatitis, as was the case for our patient.
What about for your differential diagnosis of myocardial infarction?
Doctor, for that we can request for the cardio biomarkers of troponin and creatinine kinase. So that will help us rule out the myocardial infarction.
Okay. So serum AFP was also done in this patient. So what is this test for, and why do you think this was requested on the patient?
CM, the first part was not clear for me.
In the workup that was done, serum AFP was requested, correct? Which revealed normal level. So why do you think this was done on the patient, and what is this test for in general?
Phytoprotein levels would help us to figure out if there is any sort of hepatic cancer, like it's elevated in hepatoma and hepatic carcinomas. So, this patient has a history of alcohol like consumption since the age of 22, but we could also, that would help us with the diagnosis.
Okay. So you came up with the diagnosis of Brugada syndrome, correct? So what is the most common profile of patients afflicted with this condition?
Doctor, most of the patients will usually have a family history of sudden unexplained death in a close relative. And then if there were ECG testing done before, then there can be a type 1 ECG Brugada sign. And there can be arrhythmia related conditions like the patient experiencing syncope or seizures or nocturnal agonal respiration. So that is how it is.
What about with the age and possibly racial predilection? Is there a common profile?
Yes, in young athlete males, so from male to female, it is about 9-1. So it is more common in males who are Asian and more commonly seen in the athletic population also.
Okay. So for my last question, aside from genetic testing, if the family's patient was financially constrained, what other screening tests can you offer to the relatives to test for this condition.
Doctor, we can test using the sodium channel blockers and look for the ECG if we find any abnormalities.
So you're gonna do a provocative test. It's like a drug challenge, correct?
Yes, sir.
So I have no other questions for the group. So congratulations again and good luck on your on the CPC.
Thank you.
Thank you,
On behalf of the team, we would like to thank you for your time and for your presence here and for being a part of our CPC. So thank you.
Okay.
God bless.
Happy to be here. Yeah.
Dr. Alaika, thank you for throwing those very interesting questions to our students. Do you have any insight regarding this activity?
Yes, Doc. I think it's an excellent form of learning. It's a good learning activity for the medical students because it helps them develop their clinical problem-solving skills, and it can also be done in a virtual setup. So, especially now in the midst of a pandemic, I think it's a good activity. It's a good exercise.
Thank you, doctors, students. You may now leave the chat.
Thank you, Dr. Akaindek.
Thank you. Stay safe, everyone. Thank you.
The second group to present is Voldemort, judged by Dr. Cybel A. Nang. This group is mentored by Dr. Marlon A. Briones, together with our guest mentor from the Department of Pediatrics, Dr. Jeheris Ocampo.
Years later, after the Second Wizarding War, when everyone thought that the world had peace, his loyal followers still had hope that he would come alive again. So they sought to find the only Horcrux remaining, one that no one knew about. He will rise again, and the world will live in the fear of Dark Lord.
The ministry has fallen. The minister of magic is dead. They are coming.
After all, he was Lord Voldemort, the most terrifying wizard to have ever lived. And we are Death Eaters, loyal followers of Lord Voldemort.
Five of the best Death Eaters escaped Azkaban and came to the Muggle world to avenge their fallen.
Well, for general data, our patient PD was a 27-year-old male from West African sector, and I remember his chief complaint was dyspnea.
Well, 3 days before consultation, he just returned from his short vacation football training and later in the afternoon developed abdominal pain. Now he just took an antacid thinking it was due to skipping his lunch and breakfast. Now 2 hours prior to consultation, he fell unconscious while teaching and his friends rushed him here. Well, 2 months ago, there was right bundle branch block noted in his ECG. And oh, look at his family history. His grandma is positive for gastric cancer. His cousin has leukemia. His father is diagnosed with liver disease. And this is important. His brother had sudden unexplained death syndrome.
When we reviewed our patient, we found that the patient had abdominal pain, dyspnea, but he did not exhibit any signs of nausea, vomiting, diarrhea, dysuria, hematuria, and jaundice. The physical examination findings of our patient includes blood pressure of 140 by 90 mmHg, heart rate of 100 beats per minute, respiratory rate of 30 breaths per cycle, and the heat includes a pale palpable conjunctiva was found and there was no tonsil or pharyngeal congestion seen. The chest and lungs showed increased breath sounds on both lung feeds with no wheezes and no rales. There was increase in heart rate with no murmurs, and in the abdomen there was negative kidney punch.
The initial impression of the patient is dehydration due to excessive exercise leading to acute myocardial infarction.
He was sent to the emergency room of the St. Mungo's Hospital, where he was hooked onto oxygen and kept under observation to check for any progression for symptoms. Laboratory tests such as blood chemistry, complete blood count, peripheral blood smear, chest X-ray and ECG were done. He was advised to get admitted in the hospital, but he opted to go home and went against medical advice.
24 hours post home against medical advice, patient was apparently well and then he resumed drinking session with his friends and then went home. After few hours, patient fell asleep and then he seen moaning and gasping for breath and he observed to be not breathing at all. Then the patient was rushed to the emergency room again. There, he seemed to be pulseless and aggressive CPR was initiated and then was subsequently declared to be dead.
In his complete blood count, I could see decreased WBCs, increase of RDW and lymphocytes. In his peripheral blood smear, it reveals that he has normocytic normochromic red blood cells. White blood cells are within normal with neutrophilic predominance. Few juvenile forms and stab cells are noted. The platelets are adequate and the rest of the blood chemistry along with immunology is normal as all the limits are within normal.
The ECG of the patient is showing Brugada pattern with ventricular fibrillation and ventricular tachycardia. Coved ST segment elevation is also noted. In his chest X-ray, there is elevated left hemidiaphragm. Stomach is distended due to gas bubble formation. A pulmonary thromboembolism is also noted and left ventricular hypertrophy is seen.
So what are your differential diagnoses?
Could he have had acute myocardial infarction as he has tachycardia, he has a history of sudden death syndrome, ST elevation in his ECG and abdominal pain?
No, we cannot consider this because the patient is not having any chest pain, there is no nausea, vomiting, there is no sweating and he also not having any anxiety.
Or could it be hypertrophic obstructive cardiomyopathy as he is a young male adult of 27 years old, has a family history of SUDS, is an athlete, has an episode of syncope, has nocturnal dyspnea, his lung exam is normal and he shows inverted T wave in ECG.
No, it cannot be that since the patient ECG is not showing any dagger-like septal Q wave, he is not having any orthopnea, dizziness, there is no leg edema, no murmurs are heard in this patient and also he is not having any palpitations.
Or could it be arrhythmogenic right ventricular cardiomyopathy as he had an episode of syncope, is a young male adult of 27 years, has a family history of SUDS, is showing inverted T wave in ECG, is an athlete, has abdominal pain and is an alcoholic.
This cannot be considered because the patient's ECG does not show any epsilon wave in V1 to V3 precordial chest leads. He has no lightheadedness, no dizziness, no leg edema, there are no palpitations and there is no abdominal swelling.
Oh wait, let me help you out. It has to be type 1 Brugada syndrome, secondary to sudden cardiac death. Because our patient had a positive family history of sudden cardiac death, there was syncope, there was dyspnea, there was gasping for breath, there was increased respiratory rate, there was ventricular fibrillation, there was ventricular tachycardia, the ECG showed coved ST segment elevation, there was T wave inversion in the ECG as well, there was nocturnal agonal respiration followed by death. Now discussing the pathophysiology of the patient. Alterations in the ion transport channel causes abnormalities in depolarization or repolarization of cardiac cycle. Structural abnormalities in such cases of congenital or acquired heart diseases leads to change in the cardiac tissue that alter the impulse conduction. Acute myocardial infarction, electrolyte disturbances, and concomitant drugs trigger events that precipitates ectopic electrical activity and multiple micro re-entry circuits interpreting with the normal conduction, leading to disorganized ECG and disorganized electrical activity, causing uncoordinated ventricle contraction, hence leading to ventricular fibrillation. This causes type 1 Brugada ECG ventricular arrhythmia. Due to impaired ventricular contractions, there is no cardiac output produced, leading to global hypoperfusion, causing dyspnea, hypoxic brain, and multi-system organ failure. Alcohol intoxication also contributes to this. The impaired ventricular contractions with no cardiac output leads to cardiac arrest with no heart rate, no BP, and no palpable pulse, and syncope. Loss of consciousness or syncope leads to brain damage or brain death, further causing sudden unexplained nocturnal death. The hypoxic brain and the multi-system organ failure also contributes to the sudden unexplained nocturnal death.
As for the management, Brugada syndrome can only be managed by treating other comorbidities like ventricular tachycardia, fibrillation, and preventing sudden cardiac death by implanting cardioventricular defibrillator. And radiofrequency catheter elevation is the technique recently effective in patients with Brugada syndrome as well.
Now we have come to a conclusion with the cause of death. The immediate cause of death is the sudden cardiac death. The antecedent cause of death is the Brugada syndrome. The underlying cause of death is hypoxia, ventricular fibrillation, tachycardia, and multi-system organ failure. Now contributing cause of death or other significant conditions are dyspnea, syncope, alcohol intoxication, and history of the right bundle branch block.
Chief complaint has been covered in the history of present illness. Has the symptom analysis enough to give you any clinical impression like the chief complaint? Anyone?
Doctor, I would like to answer this question.
Okay.
In our case, the chief complaint is dyspnea, and in that case, if you see, our patient has been complaining of abdominal pain as well, and the patient has syncope, and that's how his friends brought him to the hospital.
Okay, so number 2 question. What's the expected cardiac physical exam for the RBB? It was mentioned that the first ECG, though it was not shown in the protocol, the ECG findings of right bundle branch block. So what do you expect as a physical exam? Expected cardiac. What should you be looking for? If you saw the ECG, it's right bundle branch block. What should you be looking for?
In the ECG, we would see that there is
another person should answer.
May I, doctor?
Okay.
Yeah, in the ECG for the RBB, we should be looking for the QRS complex of it should be more than
physical exam. No. Physical exam. Cardiac physical exam.
Cardiac physical exam.
Yes. I heard you're like 3rd year student, so 2nd year it's the physical exam. So what are the physical exam that you should note? If you saw the ECG, it's the right bundle branch block.
Doctor, when in the physical exam for RBBB, we should be looking for murmurs and any abnormal heart sounds?
Like?
Like there will be a split S2 heart sound, doctor.
Okay, was it noted at the patient?
In our patient, there were no split heart sounds and no murmurs.
So the third question would be any other differential diagnosis other than the one that you mentioned? What else? In relation to the history and the PE and the laboratory exam that was done to the patient, what are the other differential diagnoses that you can deduce from that?
We can give acute myocarditis because of the physical examination and the ECG also. Because it's ventricular.
Yeah, you mentioned there was no murmur, there was no abnormal sound that was noted, right? So in myocarditis, if you're entertaining myocarditis, what are the expected physical exam?
There would be chest pain and all, but that was not there, so we ruled it out. And there was no murmurs also heard.
Okay, did you ever consider Marfan? Any aneurysmal rupture? Or since this is an acute onset, very fast. Okay. So number 4 question, the cardiomegaly noted, is it congruent with the physical exam and the X-ray finding? You guys keep on noting that there was cardiomegaly, but in the protocol, I don't see any cardiomegaly. Can you point it out to me where you find the cardiomegaly that you are talking about?
Doctor, we haven't mentioned cardiomegaly in our report. We had mentioned left ventricular hypertrophy.
Oh, where is it? Where did you correlate that in the laboratory, in the physical finding? If you have left ventricular hypertrophy, what is the expected PE of this patient and what is the expected ECG findings on this patient? For you to say that probably this patient has LVH.
Well, according to the ECG, there's a ST elevation in the precordial leads, that is the V1 to V3. So that can be a finding of left ventricular hypertrophy also.
No, that is an indication that there is a myocardial injury. But what is the lead that is used to identify the left ventricle in the ECG?
The lead used to identify the left ventricle, doctor.
Yes.
It would be from V4 to V6.
Yeah. So what is the finding? Is it increased by what criteria are you using? The soliloquy, the criteria are you using to measure the size of the LV of the patient?
We actually measured the size of the left ventricle, doctor, in our given chest X-ray. And we can also see some ST elevations in the ECG of our patient, which made us conclude that our patient is having left ventricular hypertrophy.
In a young patient with no comorbidities. In an athlete.
Yes, doctor, because in our case, the patient is an athlete he might be doing some strenuous activities which might lead to his left ventricular hypertrophy, because he'll be having more endurance.
Did you pay particular attention to the view of the X-ray? Sometimes the view of the X-ray would magnify the heart, but not necessarily that the heart is big.
Doctor, for our patient, we just we went with the ECG and the chest X-ray that was given. We didn't. We were not able to clearly find out the other views and what difference it would make. But from the ECG, as the other defenders have previously mentioned, we could see ST elevations, and when we went through the chest X-ray, we could see the left ventricle a little bit dilated, so we opted for left ventricular hypertrophy.
Okay. Just to remind you, LVH is not in any way related to the ST elevation. It only signifies that the ST elevation, there is an obstruction. There was an injury on that part, on the side of that heart. The blood supply that is supplying that part of the heart. But it's not in any way related to the size of the heart. You can have an MI even if you have a normal sized heart. So my last question would be, what is the use of the HIV hepatitis
question?
The last question, yeah. What is the use of the HIV hepatitis testing in this case?
Doctor, we just want to confirm if the patient has hepatitis or not, in case he had come in contact with any infections in previous, because we don't have a detailed history. We just given a part of the history. Whatever we have, we couldn't conclude anything related to hepatitis, so that's why we didn't consider the immunological studies.
Thank you for your time, Dr. Renang. We hope to see you again next time.
Kindly send na lang po into my email po. Thank you.
The third group to present is Dorm Strong, judged by Dr. Rosini L. Briones Ruiz. This group is mentored by Dr. Rogelio Costa and together with our guest mentor, Dr. Audrey Angeli Andres from the Department of Obstetrics and Gynecology.
Fight every battle, everywhere, always, in your mind. Everyone is your enemy. Everyone is your friend.
I summon with poison and summon with pain. From the dark they call you, into the dark they call you. Here in darkness we summon you together.
The hunt is on, true aim is clear. My prey will become
Age 27-year-old male. Nationality West African. Past history right bundle branch block on ECG. Family history positive for gastric cancer, leukemia, liver diseases, SUDS, that is sudden unexplained death syndrome. Personal history drinks alcoholic beverage on an average of 5 to 6 bottles of beer occasionally since 22 years of age. Patient does not smoke or takes prohibited drugs. Chief complaint dyspnea. History of present illness. He complained of having abdominal pain, non-radiating, occurred in the late afternoon. This was dismissed by the patient as acclimation since they only eat dinner. They skipped both breakfast and lunch. Patient took an antacid and afforded symptoms relief. 2 hours prior to the complaint, patient developed an episode of syncope while teaching high school students the essentials of football, prompted his friends to rush him to the hospital. Review of system. Positive for abdominal pain and dyspnea. Negative for diarrhea, nausea, vomiting, jaundice, dysuria and hematuria.
As for the salient features, dyspnea, which is the patient's chief complaint, syncope, alcohol intake history mentioned in the personal history of the patient, ST segment elevation to more than 1 mm in V2 and V3, followed by a negative T wave that was visible on the ECG of the patient, and myocardial infarction in ECG. Our initial impression is pulmonary emboli. As for the approach to dyspnea, dyspnea is categorized as either acute or chronic. Patient had an acute dyspnea, which is a sudden onset, along with tachycardia and syncope. All these led us to consider a cardiopulmonary involvement, adding other factors, thus leading to the following differential diagnosis: pulmonary embolism, hypertrophic cardiomyopathy, gastroesophageal reflux disease, and Brugada syndrome.
Now we shall be looking at our various differential diagnoses, the first one being pulmonary embolism. The rule-ins for pulmonary embolism are the presence of dyspnea, tachycardia, tachypnea, ventricular dysfunction, and the presence of syncope. The rule-outs for this condition are the fact that the patient was less than 30 years old, he was a non-smoker, there was no surgery in his past history, and that his ECG reading showed ST elevation greater than 1 mm in V1 and V2 with negative T waves. Also, the patient had family history of SUDS and was a regular intaker of alcohol. The next differential diagnosis will be hypertrophic cardiomyopathy. The rule-ins for this condition are presence of dyspnea, presence of syncope, the fact that the patient had family history of SUDS, and the fact that there was sudden cardiac death. The rule-outs for this condition are the fact that there were no murmurs, no enlargement of the heart, and that the ECG reading showed ST elevation greater than 1 mm in V1 and V2 with negative T waves. Our third differential diagnosis will be gastroesophageal reflux disease. The rule-ins for this condition are the presence of abdominal pain, the fact that the patient was an intaker of alcohol, the fact that the abdominal pain was relieved by use of antacids, and also the fact that the patient had family history of gastric cancer. The rule-outs for this condition are the fact that the patient was a non-smoker, presence of dyspnea, syncope, the ECG reading showing ST elevation greater than 1 mm in V1 and V2 with negative T waves, the presence of ventricular dysfunction, and the fact that the patient had family history of SUDS.
Brugada syndrome. Here are the rulings that we consider Brugada syndrome as one of our differential diagnoses. Dyspnea, family history of SUDS, history of right bundle branch block, syncope, alcohol history in intake, LVH in history, ST elevation more than 1 mm in V1, V2 and negative T waves, ME in ECG and sudden cardiac death, and there are no rule-outs in Brugada syndrome. Chest X-ray. No correlation between findings of X-ray and initial complaint or cause of death. ECG findings: left ventricular hypertrophy, ST elevation more than 1 mm in V1, V2 and negative T waves.
Pathophysiology. In this case, we have identified 3 factors that have played a major role in leading to the patient's death. All 3 of these factors converge at one point, creating a sort of concoction that rapidly decreases the patient's chances of survival. Starting off with the first factor, which is the depolarization and repolarization hypothesis, in which there is mutation of the SCN5A gene, which causes a change in structure and function of sodium channels, which in turn decreases inward sodium current in cell membranes of the ventricular outflow tract. This decreases magnitude of action potential, which slows down electric conduction along the cardiac muscle, leading to ventricular fibrillation. The second factor that we have to discuss about is the structural abnormalities hypothesis, which talks about the scarring of the right ventricular outflow tract, leading to a right bundle branch block, which in turn leads to ventricular fibrillation. Now moving on to stress factors, of which the first being training high school students, which is a physical activity, which leads to tachycardia and in turn leads to ventricular fibrillation. From there, we notice that there is a decreased cardiac output, leading to hypoperfusion of all tissues, leading to syncope, which explains the initial encounter of the patient in the hospital. The second sub-factor is alcohol intake, which consists of two mechanisms of operation. The first being, it acts as a sodium channel blocker, directly causing ventricular fibrillation. The second being, it causes dehydration due to its diuretic effect, in turn increasing the blood pressure, causing tachycardia and leading to ventricular fibrillation. From there, ventricular fibrillation leads to decreased cardiac output, leading to hypoperfusion of all tissues, which in turn leads to cardiac arrest and shortness of breath, and eventually death. Cause of death. The immediate cause being ventricular fibrillation, the antecedent cause being Brugada syndrome, and the underlying cause being tachycardia inducers. That would be alcohol intake and physical activity. Genetic testing and genetic counseling. Testing for Brugada syndrome may include full sequence analysis, deletion or duplication testing, known familial mutation analysis, or multi-gene panels, along with full sequence analysis of the SCN5A gene. It also helps to identify families at possible risk of a genetic disorder, gather and analyze family history and inheritance patterns, calculate risks of recurrence, and provide information about genetic testing and related procedures.
Underneath the bridge, top has sprung a leak, and the animals have trapped.
Okay. For your case, initially you diagnose a patient with pulmonary embolism. If you were the attending physician in this case at the emergency room, what other diagnostic examinations will you do to really verify your diagnosis of pulmonary embolism? Anybody can answer.
Doctor?
Okay.
Yeah. We could perform a D-dimer, which should be definitive. Also, X-rays, maybe. Yeah. Suman, you were trying to say something, yeah?
In X-rays, what can you find for in pulmonary embolism? What are the findings in pulmonary embolism for X-rays?
There was a sign, right? I forget the name of the sign.
The sign, there would be like the Westermark sign, which would be indicative of the pulmonary emboli. So that's one thing in the X-ray which we'll be looking out. Like if you're looking for pulmonary emboli, that's one sign which you're supposed to be looking out for.
All right. What other diagnostic tests can you ask?
You would look for the pulmonary angiography to rule out the pulmonary embolism. You look for the pulmonary angiography. For physical findings, you look for any swellings in the legs or something like that.
Because nowadays, pulmonary embolism is common for patients who have COVID infection. There are several other tests that you can do first before X-rays or like in blood exams. Can you name some?
We can check the serum troponin level because it can be elevated in like 50% of the patients who are having like pulmonary embolism.
Right.
We also check for the ECG. In pulmonary embolism, there will be a long S wave in the lead bone, and in our case, there is no long S wave in the lead bone. And as like in pulmonary embolism, there will be Q wave in lead 3, but we don't have Q wave in lead 3. So these are the things that we consider that pulmonary embolism is not our final diagnosis. We thought it's just an initial impression. Then when we further work it on, we thought it is not it's not our final diagnosis. Then we move on to the other diagnosis that would exactly match our case. And then second thing, we go for the hypertrophic cardiomyopathy.
Okay. Also, why did you consider initially pulmonary embolism in a patient who is a young person and athletic?
Since the patient presents with dyspnea, first of all, when we encounter a patient without, since the patient is dyspnea and he has a tachycardia and he has an abdominal, so we thought it's a pulmonary embolism. Maybe it's a pulmonary because we can see dyspnea. When we think of the dyspnea, first thing we come to our mind when we look for the pulmonary embolism is when we look for the pulmonary case, it's a pulmonary embolism. So we think that is our initial impression. So that's why we took it as an initial impression.
Okay. For the other tests that you can do a D-dimer and a CT scan to diagnose pulmonary embolism. And we go to your final diagnosis of Brugada syndrome. What clinical situation may unmask or exacerbate the ECG pattern of Brugada syndrome?
In ECG, we have a ST elevation more than 1 mm in V2 and V3. It is a typical Brugada pattern. It's a typical type 1 Brugada pattern. So first of all, we consider it as an hypertrophic cardiomyopathy. When we look on the X-ray, we definitely there is a typical Brugada pattern, like I said, ST elevation more than 1 mm. So we jump to the Brugada pattern.
But what clinical situation may unmask the Brugada syndrome in ECG? For example, if you have a patient in a clinic coming into you, and then you want to really know if the patient has Brugada syndrome, what details can you ask the patient, or what other symptoms that the patient?
We would ask for whether the family history, whether he had a whether the patient has a sudden family history of sudden cardiac death or a Brugada syndrome. We would first look for we look for the family history. First thing that we ask is the family history for regarding Brugada syndrome.
Doctor, also given the case that what we notice is that the patient does have a history of RBBB in a previous ECG. So considering that and the fact that the patient does have syncope, and on examination of the ECG, we notice a clear type 1 Brugada pattern. We came up to it being definitive of Brugada syndrome.
Okay.
Yes? Yeah, I would like to include also the fact that what happened at the end, it was at night and when the patient was at rest, which is typical in Brugada syndrome, like nocturnal events.
How can you correlate the drinking session of the patient or the alcohol intake of the patient with the death or the symptom of the patient for the syncope?
Doctor, because what we usually notice in with regard to the pathophysiology of Brugada is that it eventually leads up to ventricular fibrillation, which in turn leads to any kind of tachycardia leading to ventricular fibrillation, and then it goes down the chart that we've depicted in our pathophysiology, right? So alcohol intake, alcohol itself can cause, there are two ways, like in our PPT, we've pointed out, like especially the flow chart, that, just a minute, let me just pull that up. Right, alcohol intake does act on the sodium channels directly as a blocker, therefore causing ventricular fibrillation. Also, alcohol intake has a dehydration factor secondary, causing an increase in blood pressure, leading to tachycardia, again causing a risk of ventricular fibrillation, and then from there on, it goes down as the same pathway as the chart that we've put in our pathophysiology.
How about the electrolytes? Did you check on the electrolytes?
Electrolytes, as in the case report?
Yes, as indicated in your case, the electrolyte imbalance.
Doctor, we have not seen any signs of electrolyte imbalance.
Or
also
for the alcohol intake, because the patient had an alcohol intake, can you correlate it with the electrolyte imbalance?
But then the question pops up as to where the electrolyte imbalance could have been from. We have to consider the fact that the serology report that has been given to us was taken on the initial day of admission. So this is before the patient had even consumed alcohol, right? Because he got discharged and then he went out and then he started drinking. So considering that into factor, we can't really talk about serology post alcohol intake because we don't have that information with us.
Okay, because alcohol intake can cause hypokalemia, so it can lead to the exacerbation of the syncope or the atrial fibrillation, or rather ventricular fibrillation of the patient. I think we got only a minute, so how is ventricular tachycardia managed in Brugada syndrome?
The only treatment for Brugada, it would be preventive, which would be an ICD, because the only way because once the patient reaches ventricular fibrillation, right, the situation only gets out of hand. That's when you notice that the mortality rate increases substantially. So what would be a preventive measure is to prevent the onset of ventricular fibrillation, because tachycardia is something that you can't really entirely control, because human life has stress factors and many other conditions that induce tachycardia. But what we can prevent is an arrhythmia from popping up during a stressful period, a tachycardic period. So an ICD is anything that we can move forward with as a preventive measure, of course.
Okay, I think that's it.
Okay, I'm stopping the timer. Thank you, Team Dermstrang, for your answers and your input. Thank you once again. You may now leave the chat. Dr. Ruiz, may we please get some additional comments from you about the CPC so far?
I think I have some points here for the students that my points are they should be engaging with the audience. It's more on how they speak. They should be engaging, that they can see that the audience are really listening to them, and then they should be cohesive and concise. They should give a clear logical flow of the case presentation, and in the end, sometimes at the end they just stop presenting. I think in the end they should do a summary of the presentation. And for the slide designs, some do a lot of stops or other animations that are too much, and they keep the audience they keep the audience away from the presentation, because when you look at the slides, it is so populated that they should be doing it less, because yes, when we do presentation, less is more. I think that's all.
All right. Thank you, Dr. Ruiz, again. Thank you.
Thank you.
Good afternoon po ulit.
The fourth and last group to present is Elver Moni, judged by Dr. Sarah Jane Datay Lim. This group is mentored by Dr. Diane Jin Sope and Dr. Iftizar Haron, and together with our guest mentor, Dr. Ethel Garcia from the Department of Internal Medicine.
From darkness to wilderness to the nothingness of horizon. With my name she runs down the spine of your funny creatures. Yet you pretty delicate, had the nerve to read it all skin. For it is me, and inside that vengeance will be mine.
Hey, you can be the greatest, you can be the best, you can be the wizard king down from the west, you can be the world, you can be the war, you can hang around the world, hang around you, you can be the ones out, you can be the globe, you can be the compass, break up bones, you can be the doctor, no way for love, you can be the self and look friendly, so we can only fight together, keep us safe from the light. Together we stand as one. So we will fight together as one. Keep us safe from the dark. Together we stand as one.
Good day. For today's case, we have a 27-year-old man who's of West African nationality, and his chief complaint is dyspnea. History of present illness. The patient is a professional football player who was apparently well until 3 days prior to consultation. He complained of abdominal pain, which was non-radiating, and it occurred in the late afternoon. This was dismissed by the player as acclimation since they skip both breakfast and lunch and have only dinner. The patient took an antacid, which afforded symptoms relief. 2 hours prior to consultation, patient developed an episode of syncope while teaching high school students the essentials of football, and he was rushed to the hospital by his friends. The patient's past medical history is significant for right bundle branch block, which was noticed in an ECG that the patient had taken 2 months ago. His personal history includes the fact that he is an athlete who eats healthy foods, and he drinks 5 to 6 beers on average on an occasional drinking session, which he started at the age of 22. The patient does not smoke or take prohibited drugs. The patient's family history is significant for gastric cancer, leukemia, liver disease, and sudden unexplained death syndrome. The patient's review of systems pertinent to this clinical visit include positive abdominal pain and positive dyspnea. The patient does not suffer from diarrhea, nausea, vomiting, jaundice, dysuria, or hematuria. Physical examinations reveal the patient to have a blood pressure of 140 by 90, meaning he is hypertensive, a heart rate of 100, and a respiratory rate of 30 breaths per minute. He presented with a pale palpebral conjunctiva and no tonsillopharyngeal congestion. His chest and lungs were significant for increased breath sounds on both lung fields. There were no rales or no wheezes. There was an increase in his heart rate, but no murmurs were heard. And in his abdominal physical exam, no kidney punch was noticed.
Now, we move over to our patient's laboratory examination. Our patient's complete blood counts revealed a decrease in the white blood cells, as well as an increase in the red distribution rate and lymphocytes. Our patient's peripheral smell revealed normocytic, normochromic red blood cells. White blood cells were within normal and with neutrophilic predominance. The few juvenile forms and stab cells were noted, and the patient's platelets were adequate. No blast cell was noted on the examination of the smell. For our patient's blood chemistry, all labs were normal and within reference range. Also, all hepatitis markers were non-reactive. Chest X-ray was carried out on our patient, and it revealed a normal-looking chest. On our patient's ECG, we noted coved types ST elevations and T-wave inversions in V1, V2, and V3. Cost in the ward. At the emergency room, our patient was hooked up to oxygen and was observed for a few hours for symptom progression. At this point, the laboratory workup, which we've already discussed about, were done. The complete blood count, the blood chemistry examination, the peripheral blood smell, and the chest X-ray and ECG. Admission was advised, but the patient opted to go home against medical advice. 24 hours post that, our patient was apparently well and resumed drinking sessions with his friends and went home. Few hours after that, our patient fell asleep and was abruptly moaning and gasping for breath and was observed to be not breathing at all. Our patient was rushed to the emergency room again, and our patient was pulseless and aggressive CPR was initiated but was subsequently declared dead. Based on our patient's history and the labs given, especially the ECG, our initial impression is Brugada syndrome.
Okay, so let's see the differential diagnosis. Our first differential is hypertrophic cardiomyopathy, that is HCM. We ruled it in because it is more common in young adults less than 35 years old. Our patient had a family history of sudden death syndrome in his life. He is athlete by profession. He had dyspnea and syncope. We ruled it out because there was no left ventricular hypertrophy, no palpitations, no murmur, and there was no mention of S2 and S4 heart sounds. Our next differential is long QT syndrome. We ruled it in because it is more common in athletes, that the prevalence rate is 1 in 250. The triggers such as exertion can be ruled in as our patient is an athlete. He had syncope and he had family history of sudden death syndrome. We ruled it out because there was no palpitations, no QT prolongation, and no torsade pointing. Our next differential is Wolff-Parkinson-White type 1 syndrome, that is WPW. We ruled it in because it is more common in males. The male to female ratio is 2:1. The patient had syncope, dyspnea, increased heart rate, sudden death of the patient, and there was right bundle branch block. We ruled it out because there was no delta wave, no wide QRS complex, no short PR interval, and no ventricular fibrillation. Our next differential is pulmonary hypertension. We ruled it in because the patient had dyspnea, syncope, increased heart rate, abdominal pain, alcohol take, and increased breath sounds on both lung fields. We ruled it out because there was no cyanosis, no peripheral edema, no systolic murmur. There was no mention of jugular vein distension, and the right ventricular hypertrophy was not seen in just X-ray. Our next differential is type 1 Brugada syndrome. We ruled it in because of the type 1 Brugada pattern on the ECG, that is ST elevation greater than 2 millimeters, downsloping ST segment, and inverted T wave. The patient had tachycardia, sudden death in a young healthy adult, nocturnal agonal respiration, family history of sudden unexplained death syndrome, previous right bundle branch block, unexplained syncope. He had history of consumption of heavy meal and alcohol prior to the manifestation of symptoms. It can be ruled out based on the ethnicity, as type 1 Brugada syndrome has low prevalence among the African individuals. But as it is said, medicine is a science of uncertainty and an art of probability. So in this case, our most probable final diagnosis is type 1 Brugada syndrome.
So, what is Brugada syndrome? Brugada syndrome is an inherited disease that predisposes the patients to fatal cardiac arrhythmias. This syndrome is characterized by ECG findings of right bundle branch block and ST segment elevation in the right precordial leads of V1, V2, and V3. In a consensus published in the year 2005, the definitions were revised and a definitive diagnosis of Brugada syndrome was considered when type 1 ST elevation is observed in more than one right precordial lead, either spontaneously or following drug provocation, in conjunction with one of the following documented ventricular fibrillation, polymorphic ventricular tachycardia, a family history of sudden cardiac death at less than 45 years of age, coved type ECG in family members, inducibility of ventricular tachycardia with programmed stimulation, syncope or nocturnal agonal respiration, which is attributed to self-terminating polymorphic ventricular tachycardia or ventricular fibrillation. Moving on to the pathophysiology of Brugada syndrome. Brugada syndrome is a channelopathy, that is, there is a malfunction in the voltage-gated sodium channels present in the heart and is caused by a defect in SEN5A gene. It exhibits autosomal dominant inheritance pattern with SEN5A, which encodes for cardiac sodium channels. This sodium channel defect is mostly found in the epicardium of right ventricle, creating a voltage gradient between the endocardium and epicardium of the heart. This makes the electrical impulses between the ventricles to become uncoordinated, leading to ventricular tachyarrhythmias. Now, there are certain trigger factors like alcohol, hypothermia, vigorous exertion, and certain medications that can aggravate the Brugada syndrome. These fatal tachyarrhythmias causes impaired cardiac output and a decreased blood flow to the brain and heart, causing syncope and cardiac arrest, which in turn leads to a global hyperperfusion with no palpable pulse, resulting in sudden death.
Management. The main aim when treating people with Brugada syndrome is to reduce the risk of sudden death due to serious abnormal heart rhythms such as ventricular fibrillation or polymorphic ventricular tachycardia. The only proven therapy is an implant cardioverter or defibrillator or ICD. If in case the ICD does not work effectively, a catheter ablation is preferable. Quinidine, isoprenaline infusion has been proposed as an alternative in this setting. Then comes recommendations. The patient in question could have been advised to modify his dietary habits, such as unusually large meals have been shown to precipitate cardiac dysfunction within 2 hours of consumption. Given the susceptibility of the patient, he could have been advised to abstain from heavy alcohol consumption, as electrophysiological studies have shown that acute alcohol administration facilitates the induction of tachyarrhythmias in selective heavy drinkers. Additional testing during the course of ward. On hindsight, the patient may have been benefited from the additional diagnostic test, including drug testing, signal average ECG, electrophysiological testing, and genetic testing. For the cause of death, we have considered sudden cardiac arrest as immediate cause, followed by ventricular tachyarrhythmia as the antecedent cause, and finally, for underlying cause, we have considered Brugada syndrome.
All right. So any member of the group can answer my question. So my first question would be on the first part of the presentation. So for the salient features, you mentioned that the patient is of African race and the work of the patient. So what is the significance of knowing this, the race and then the work of the patient? Is this related to the diagnosis?
Yes, doctor, I would like to take this question. So, based on the work, he is a football athlete by a profession. So, we thought of some there are many cardiac issues related to the in an athlete. They are more common, and also he had family history of sudden death, and also the patient died suddenly in his sleep. So yeah, we thought that our final diagnosis should be based on some cardiac issue, as the patient is an athlete. Mostly, if in athletes, if you consider the most common cause of sudden death is usually CAD, if the patient is greater than 40 years old. And if the patient is less than 40, mostly the cause is cardiomyopathy. So yeah, that's why we consider the profession in this.
How about the race? Did you research if this is more common in that population or in that specific race?
Yes, doctor. Regarding a final diagnosis, which is Brugada syndrome, actually, we found a very low prevalence among the African nationals, but since all of the symptoms were, we could rule in, so that's why we consider that as our final diagnosis.
All right. So I would like to go now to the laboratory findings. Could you explain the laboratory findings, particularly the chemistry tests? So which would be important to note? And what is your comment on the test? Because they are all normal. So is this related to the diagnosis?
Doctor, I'd like to answer the question. So, the lab results are normal, which means there are a lot of things that we could rule out, especially GIT causes. So we could rule those causes out. And for most times for cardiac causes, we should be looking for troponin levels, but that wasn't available. And for cardiac, we'd look at the ECG. But the labs were normal. They rule out a lot of GIT conditions.
And so with the normal electrolytes, is this compatible with your primary diagnosis?
Yes. Yes, normal.
Yeah, because I think you discussed that it's related to the something about the sodium, and then what would be the expected findings of electrolyte findings in your primary diagnosis? And what happened to the patient? Is it aligned with the with the uh, with the usual picture of patients with Brugada syndrome?
Yes, doctor. For the sodium, I think the sodium channels are the ones that are usually defective in Brugada syndrome. So it's only sodium abnormality that we should be looking for, which was not given in lab exams.
Actually, doctor, I would like to add some points to that. The Brugada syndrome, it's a genetic mutation in sodium channels, and then that's what causing, ventricular tachyarrhythmias and then sudden cardiac arrest. And actually, in ECG, we saw that there's a Brugada sign, and it's it's due to MI, or it can be due to metabolic derangement. But we can rule the other causes of other diseases that mimic Brugada sign, because our blood chemistry was normal. We didn't have any metabolic derangement in that.
Okay, so how about the chest X-ray? Because you mentioned that it's normal, but is it really normal? Can you explain the chest X-ray imaging? Because the actual diagnosis was not given to us, right? So I think you should. Can you please explain? Now you have the opportunity to explain it.
Good afternoon, doctor. Doctor, we feel like the chest X-ray is normal. There wasn't any opacities noted. There was a in the basal area of the left lung. There was a bubble. We feel like it's a normal gastric bubble, and there were no hilar lymphadenopathy or anything like that. So we concluded that the chest X-ray is normal, doctor.
Okay, and so for your differentials, you place a lot of differentials, particularly on the particularly heart disorders. What about any systemic diseases that could have been presented with similarly with Brugada? Do you have any other considerations? Because most of your differentials were zeroed in on the heart.
Yes, doctor. There are several other etiologies of heart which can mimic Brugada, like RBBB, right bundle branch block, and even MI can mimic Brugada sometimes because of the ST elevation. But since our patient is a young patient with no risk factors, like the patient don't smoke or anything like that, and even the blood count chemistries were normal. So we were able to rule out those ischemic causes of death, doctor.
Okay. So can you expound on your last slide? You mentioned that you have some diagnostic modalities that you would have like to request that could have helped in the case. Can you explain why? When we weren't able to explain that in the presentation.
Doctor, we would have asked for some other drug testing to rule out, or we would have asked for drug testing in order to specify that it's actually Brugada, because there are some drugs that can precipitate it, like beta blockers, nitrates. Would have asked for more drug testing.
Anything else?
Yes, doctor, if I may add, we can do electrophysiological testing so that we can get a clear idea on the QRS complex, which is done for like 20 minutes, and then we can have we can do that electrophysiological test so that we can check on which part is bringing out the predicament in the heart. And even we can go for average ECG, signal average ECG, so that we can get the idea about the QRS complex if something's, if it's a
if there is any problem, like we're doing it for like 20 minutes, and then we can have an average signal about the QRS.
Yeah. And lastly, can you comment on the normal heart findings during the physical examination? Is this compatible with your primary diagnosis?
Doctor, the normal heart findings we got were actually given before he had the nighttime death. So I believe if they gave us heart conditions, heart exams that were at that point where he was having the nocturnal diurnal breathing, we would have seen more disorders. Just to ECG.
Doctora, to add to what my teammates were saying regarding the physical examination, the thing about Brugada condition is that very often it's only diagnosed incidentally in patients. So more often than not, the diagnostic criteria that we have to diagnose Brugada involves more the ECG signs that pertain to Brugada, for example, the Brugada sign, as well as a history of syncope or family history. So the physical examination does not necessarily need to indicate something particular to our condition.
All right, I think I'm done with my questions. Thank you very much. I think we covered a lot of questions with that limited amount of time.
Thank you, Doctor, for the extensive question. Doc, before we end, can we ask for feedback or any comment regarding this activity? Thank you.
Yeah, so I have my feedback. First, I have feedback to the group. So congratulations for the presentation. So there were some parts of the PowerPoint that were in paragraphs. So I would just like to suggest that put important points in bullets so that it would be easier to understand since you're already presenting it and then explaining it. So just highlight it on your presentation. And then also a comment is that most of your differentials are focused on the heart, different variations of electrical abnormalities of the heart. So since this is a CPC, maybe it should be a mix of the zebras and then some common ones, and then look into also other systemic diseases that could present similarly. And then especially since not all of the not everything fits your primary diagnosis, right? So you cannot exactly, everything didn't exactly rule in this particular diagnosis because we're also limited with the data that was given to us. So also it would have been helpful if you explained the chest x-ray and also the laboratory findings. I know most of them are normal. Just pick out the important negatives, perhaps, especially the electrolytes. That would have been important to highlight rather than say that everything's normal, period. And then at the end, it would have been helpful in the pathophysiology if you can, go back to your, not just your clinical findings, and then relate your primary diagnosis to what happened. Is it correlated with the laboratory findings, like the increase in RDW, the low WBC? I wasn't able to ask you this. So how do you explain that? Is it connected with that case? As well as the normal electrolytes. No? So that would have been helpful and would strengthen your discussion. And what else? And when presenting, for example, things like ECG, it would have been would be helpful if you put side by side a normal ECG, just for learning, because we're all in the learning process, so that we can really pick out, oh, that's abnormal, because the presentation is very quick, and then it's not easy to analyze that in a very quickly. Congratulations. I think the group is well prepared. Thank you.
Thank you, houses. Those were engaging, enjoyable, and informative presentations. We are about to reach the end of the second round of this grand CPC. the championship round. At this moment, it is of everyone's excitement and desire to know the final diagnosis. To discuss the final anatomic diagnosis as well as the interpretation and summary of the case, we have a very special speaker. Our speaker is a fellow of Philippine Society of Pathologists. He is also an international fellow of College of American Pathology and American Society of Clinical Pathology, a forensic pathologist trained in Center for Forensic Medicine Health Science Authority in Singapore, and a certified family physician of the Philippine Academy of Family Physicians. Doctors, let us all listen to the prosector of the case, our dearest chair, Dr. Serviliano B. Ritualo III.
Good morning. Welcome to the Prosector's Report, second part, 4th Annual Branch CPC for the March Customized Batch 2021. I am Dr. Serviliano Ritualo, Professor, Chair Coordinator of Faculty Pathology, JONELTA Foundation, School of Medicine, University of Perpetual Health, RIzal, DALTA. Disclosure: this CPC case was taken from my personal collection of postmortem cases when I was still working for United Nations Peacekeeping Forces, the World Bank Health Reconstruction Program, and the Italian Cooperation Program covering the period 2005 to 2014. Patients' personal data and the nationality in this case have been altered to protect their true identities. The case protocol has been improved for educational purposes. In March 21, 2011, a request was forwarded to me to determine the cause of death and conduct a postmortem on a 27-year-old healthy male who died suddenly. Specimens of the patient were sent to international agencies for toxicology examination, and no molecular studies were available at that time. External examination. The body was that of a young Negroid male, dressed in white t-shirt and blue shorts, showing early signs of decomposition. The height was 168 centimeters, and the weight was 85 kilograms approximate. Noted are skin scars, keloids on the anterior chest wall, along the mid-clavicular line to the anterior axillary line, left, measuring 0.5 by 0.5 centimeters. A hyperpigmented mark tattoo on the anterior surface of the right forearm, measuring 12 by 3.5 centimeters. Another hyperpigmented mark tattoo on the anterior surface, this time on the left forearm, measuring 10 by 2 centimeters. Noted are multiple scars on the anterior surface of both lower extremities, the largest measuring 1.5 by 1.5 centimeters. Photographs were also taken to ascertain the different areas where there is supposed to be injuries, taking note of any of the so-called intravenous access such as IV lines, your intubation, ECGs, pads, defibrillator marks, burns, and even CPR injuries. The serous cavities, pleural cavities in this case, showed confluent whitish patches on both lungs, and the pericardial cavity showed no cross deformity. However, the peritoneal cavity showed an area of hemorrhages in the retroperitoneal area, as shown in this photograph. Head and neck. Dissection of the head showed no subgleal hematoma. The brain showed venous congestion, edema, and weighed 1,500 grams. Cardiovascular system. The heart. The heart weighed 350 grams. Noted are peaking on the anterior cardiac surface, probably secondary to intense cardiopulmonary resuscitation measures. The aorta had smooth surface, and the vena cava showed no gross pathology. However, the section of the heart, which include the coronary arteries, which was noted to be patent, The main branch, left coronary artery, the right coronary artery, and the left circumflex artery were all patent. As you could see, the dissection was done in sections to ascertain that there will be no other cause for injury or any blockage of the arteries. In opening it up, the heart for dissection, the right ventricular wall was measured at 0.5 centimeters, and the left ventricular wall was measured at 1.5 centimeters. Open valvular measurements are as follows. Tricuspid valve at 13 centimeters, pulmonary valve at 7.5 centimeters, mitral valve at 11 centimeters, and the aortic valve at 6 centimeters. The dissection would also go into the right atrium and check for any congenital defects, just patent ovale, foramen ovale, and the integrity of the valves, tricuspid and mitral, and your quadritemini and your papillary muscles of the heart are also noted, as you could see in this photograph. Respiratory system, airway, the pharynx, hyalobone, larynx, trachea, and bronchi are all unremarkable. Lungs, the right lung weighed 510 grams, measured 27 by 16 by 8 grams. The left lung weighed 520 grams, measured 33 by 23 by 4 centimeters. Both lungs were noted to have protuberant whitish patches on the upper lobes, extending to the lower lobes. Cut section reveals edematous and reddish photosecretions in the upper and middle lobes on dissection. The diaphragm showed no cross pathology. Alimentary system, oral cavity, showed no gross pathology. Hyoid bone was intact and showed no fracture. Esophagus also showed no gross pathology. Upon dissection of the stomach, it revealed partially digested food particles amounting to 1,400 milliliters, and samples were taken for toxicological analysis. The duodenum, jejunum, ileum, cecum, colon, rectum all showed no gross pathology. The photograph shows the undigested food particles as the stomach was being dissected. The liver is reddish brown, weighs 1,500 grams, and measures 25 by 20 by 5 centimeters. Cross-section shows reddish photosecretions and congestion, shown in the picture. The gallbladder was normal and contained no gallstones. The biliary tree was patent and otherwise normal. The pancreas, on the other hand, we showed a photograph here of reddish area hemorrhagic discoloration. The pancreas is noted to be swollen and edematous, firm and hard in consistency. Here in this photograph, you could now see the pancreas having areas of hemorrhages. Microsections reveal patchy necrosis, periductal and perilobular in distribution, diffuse interstitial edema due to microvascular leakage, fat necrosis, a signer with blood vessel destruction, interstitial hemorrhage, and neutrophilic infiltrates. The kidneys. The left kidney is reddish brown, smooth surface, weighs 160 grams, and measures 14 by 9 by 2 centimeters. And the right kidney is reddish brown, weighs 140 grams, measures 10 by 5.5 by 3 centimeters. Cut sections of both kidneys shows pale-colored cortex and medulla. The ureters and bladder showed no gross pathology. The prostate also showed no gross pathology. For the endocrine system, the pituitary, thyroid, and adrenal glands showed no gross pathology. For reticuloendothelial, the spleen revealed with grayish-brown surface with areas of whitish discoloration, weighed 220 grams, and measures 14 by 9 by 2 centimeters. Cut section reveals congestion. The lymph nodes showed no gross pathology. Extremities noted no gross pathology, no fractures were noted, and the results from blood investigation showed that blood contained ethanol of 175 milligrams per deciliter. The vitreous tumor contained sodium at 120 millimoles, chloride at 90 millimoles, and potassium at 7.6 millimoles, ethanol at 120 milligrams per deciliter. The stomach contents were negative for any toxins and prohibited drugs. Our cause of death in this case, our immediate cause of death would be a cardiac arrhythmia. The antecedent cause of death is acute hemorrhagic pancreatitis, alcohol intoxication. Our underlying cause is a high probability of Brugada syndrome. And other causes, possible genetic predisposition, such as a family history of sudden maternal death. The manner of death in this case would be natural, since we have ruled out the intoxication as probably the cause of death in this case. There was no cardiomyopathy in our postmortem findings. Discussion. Background. Brugada syndrome is a disorder characterized by sudden death associated with one of several electrocardiographic ECG patterns. Characterized by incomplete white bundle branch block and ST cell elevation in the anterior precordial veins. In the initial description of Brugada syndrome, the heart was reportedly to be structurally normal, but this concept has already been challenged by molecular studies. Subtle structural abnormalities in the right ventricular outflow have been reported in most cases of Brugada syndrome. And sudden unexplained nocturnal death syndrome, or SUNS, has been reported worldwide. SUNS, or sudden unexplained nocturnal death syndrome, is endemic in the Southeast Asia and is colloquially known as mangungot in the Philippines, Lai Tai in Thailand, and Kuri in Japan. Although SUNS in Thailand and Japan had been determined to be phenotypically, genetically, and functionally identical to the Brugada syndrome, the relationship between bangungot SUNS in the Philippines and the Brugada syndrome has not yet been clarified or established. Brugada syndrome is genetically determined and has an autosomal dominant pattern of transmission in about 50% of familial cases. The typical patient with Brugada syndrome is young male, otherwise healthy, with normal general, medical, and cardiovascular physical examinations. Patients with Brugada syndrome are prone to develop ventricular tachyarrhythmia that may lead to syncope, cardiac arrest, or sudden cardiac death. Infrahysteine, conduction delay, and atrial fibrillation may also be manifestation of this syndrome. About 5% of survivors of cardiac arrest have no clinical identified cardiac abnormality. About half of these cases are thought to be due to Brugada syndrome. At present, implantation of automatic implantable cardiac defibrillator (ICD) is the only treatment proven effective in treating ventricular tachycardia and fibrillation and preventing sudden death in patients with Brugada syndrome. Pathophysiology. Brugada syndrome is an example of channelopathy, a disease caused by alteration in the transmembrane ion currents that together will constitute the cardiac action potential. Specifically, in 10 to 30% of cases, mutations in the SCN5A gene, which encodes the cardiac voltage-gated sodium channel 1.5, have been found. The loss of functions mutation reduced the sodium current available during phases 0 and 1 for the cardiac action potential. The decrease in sodium current is thought to affect the right ventricular endocardium differently from the epicardium. Thus, it underlines both the Brugada ECG pattern and the clinical manifestation of the Brugada syndrome. The exact mechanisms underlying the ECG alteration and arrhythmogenesis in Brugada syndrome are still being disputed at this point in time. The repolarization defect theory is based on the fact that the right ventricular epicardial cells display a more prominent notch in the action potential than the endocardial cells. This is thought to be due to an increased contribution of the transient outward current to the action potential waveform in that tissue. A decrease in sodium flow accentuates this difference, causing a voltage gradient during repolarization and characteristic ST elevation of ECG. Research has provided human evidence for repolarization gradient in patients with Brugada syndrome using simultaneous endocardial and epicardial unipolar recordings. This is a typical Brugada syndrome ECG showing the notch in type 1, and after several hours the notch disappears after 24 to 48 hours, as you can see in type 2 and type 3. The saddle notch is still found in the type 1 in the P2 part of your ECG. When the usual relative durations of repolarization are not altered, the T wave remains upright, causing a saddleback ECG, as shown in the ECG prior. When alterations in repolarization is sufficient to cause a reversal of the normal gradient repolarization, the T wave inverts, and the whole type 1 ECG pattern can be seen. In a similar way, heterogeneous alterations in cardiac repolarization may predispose to the development of re-entrant arrhythmias, termed phase 2 re-entry, that can clinically cause ventricular tachycardia and ventricular fibrillation. An alternative hypothesis, the depolarization conduction disorder model, proposes that the typical Brugada ECG findings can be explained by slow conduction and activation delays in the right ventricle, in particular the right ventricular outflow tract. One study used amyloid provocation to elicit type 1 Brugada ECG patterns in 91 patients and found that the repolarization abnormalities are concordant with the depolarization abnormalities and appear to be secondary to the depolarization changes. Using vector cardiograms and body surface potential maps, investigators were able to show that depolarization abnormalities and conduction delay map out to the right ventricle. Etiology in this case, the prototypical case of Brugada syndrome has been associated with alterations in the SCN5A gene, which nearly has 300 mutations that have been described. Mutations in other genes have been proposed to cause a variant of the Brugada syndrome, including the genes coding the alpha-1 and the beta-2b subunits of the L-type calcium channel, which are thought to be cause a syndrome of precordial ST elevation, sudden death, and short QT interval. Mutations in the gene GPD1L and SCN1B have been identified in a few familial cases. Cases in which mutations in the SCN5A gene cannot be demonstrated may be due to mutations of these genes or due to other unidentified genes located in the regions of the coding sequence or promoter region of the SCN5A that are not routinely sequenced in most laboratories. Many clinical situations have been reported to unmask or exacerbate the ECG pattern of group Brugada syndrome. Examples are febrile state, hyperkalemia, hypokalemia, hypercalcemia, alcohol or cocaine intoxication as in our case, and the use of certain medications including sodium channel blockers, vasotonic agents, alpha adrenergic agonists, beta adrenergic blockers, heterocyclic antidepressants, and a combination of glucose and insulin. Etiology International Statistics. The highest prevalence of Brugada syndrome is in the Southeast Asia area, and the lowest is in North Africa. In parts of Asia, Philippines, Thailand, Japan, Brugada syndrome seems to be the most common cause of natural death in men younger than 50 years of age. It is known as Lai Tai in Thailand, Mangungot in the Philippines, and Pukuri in Japan. In northeast Thailand, the mortality rate from Lai Tai is approximately 30 cases per 100,000 population per year. Brugada syndrome is most common in people from Asia. The reason of observation is not fully understood and may be due to Asia's specific sequence in the promoter region of the SCN5A. And when I was in Singapore in 2002-2003, undergoing forensic studies, they have been doing studies on Thailanders and Filipinos, and they have took note that we are what's supposed to be a salty base population. Most Thailanders and most Filipinos, for that case, always have to dip their food in fish paste, fish sauce, and uses fish paste also for food preparation, together with soy sauce from Japan. And this would have something to do with our sodium channel pathology. Brugada syndrome is 8 to 10 times more prevalent in men than in women. Although the probability of having a mutated gene does not differ by sex, and the penetrance of mutation therefore appears to be much higher in men than in women. Brugada syndrome most commonly affects otherwise healthy men aged 30 to 50 years of age, but affected patients may age 0 to 84 years have also been reported. The mean age of patients who die suddenly is 41 years. Prognosis. Brugada syndrome is a cause of polymorphic ventricular tachycardia, which may degenerate into ventricular fibrillation and cause cardiac arrest. Prolonged hypoxia during the cardiac arrest may leave patients with neurologic sequelae. Implantable cardioverters and defibrillators are often used to treat patients with Brugada syndrome, exposing them to complications related to device implantation and potential for inappropriate shocks. During a mean follow-up of 24 months, sudden cardiac death or ventricular fibrillation occurred in 8.2% of patients with Brugada syndrome. A history of syncope, spontaneously abnormal ECG, and inductibility during programmed electrostimulation significantly increases this risk. Brugada syndrome may be a significant cause of death aside from accidents in men under 40. The true incidence may not be known due to reporting biases. Although a strong population dependence, an estimated 4% of all sudden deaths, and at least 20% of all sudden deaths in patients with structurally normal hearts are due to this syndrome. Those who with this syndrome have a mean age of sudden death of 41 years plus minus 15 years. In the history, syncope and cardiac arrest are the most important or most common clinical manifestation leading to the diagnosis of Brugada syndrome. Nightmares or thrashing at night may occur. However, some patients may remain asymptomatic, and the diagnosis of Brugada syndrome is suggested by routine electrogram showing ST segment elevation in B1 to B3, showing some sort of a right bundle branch block. That's the only thing that to be shown, and most times we overlook that because right bundle branch block, even though we see that it's supposed to be acceptable in most institutions, we accept our cadets in the Philippine National Police with right bundle branch block because they say it's supposed to be a normal variant. But this could be a precursor for such a sudden cardiac death. A family history of sudden cardiac death is common, but not universal, as the syndrome may occur sporadically. In about 20% of patients, atrial fibrillation is an associated arrhythmia. The context of cardiac event is important, and in many cases, cardiac arrest occurs during sleep or rest. Cases during physical activity are rare, though may happen, and fever often reported to trigger or exacerbate the clinical manifestation of Brugada syndrome. A 2012 study suggested that the quality of symptoms prior to syncope can predict a benign or malignant cause in patients with Brugada syndrome. Specifically, the lack of a prodrome are more common in patients with ventricular fibrillation, documented as the cause of syncope. In our case, we did not see that was normal at the ER. It was a ventricular fibrillation. It was a right bundle branch block that was diagnosed. On physical examination, the physical is usually normal with Brugada syndrome. Nevertheless, physical examination is required to rule out other possible cardiac causes of syncope or cardiac arrest in otherwise healthy patients. We look for murmurs from hypertrophic cardiomyopathy or of a valvular or septal defect. In laboratory studies, we check the serum potassium and calcium levels in patients presenting with ST segment elevation in the right precordial leads. Both hypercalcemia and hyperkalemia may generate ECG pattern similar to that of Brugada syndrome. Laboratory markers such as creatine kinase MB and troponin should be checked in patients with symptoms compatible with acute coronary syndrome. Elevations may therefore indicate cardiac injury. Genetic testing. Patients with high likelihood of Brugada syndrome may be genetically tested for a mutation in the SCN5A, which codes for the alpha subunit sodium 1.5 of the cardiac sodium channel. The results of this test support the clinical diagnosis and are important for the early identification of members at potential risk. However, the yield of genetic testing remains relatively low at this time, and mutations in the SCN5A are only found in 11 to 28% of index cases. In the Philippines, the use of bangungot, the term, is confusing and includes many other diseases that may cause sudden, unexplained nocturnal death. Review cases reveal a notable subset of bangungot identified as bangungot sons with no gross cardiac pathology that conforms to the clinical picture of the folk belief of bangungot and of the Brugada syndrome, mainly predominance among male in the 20 to 40 age range, sudden death during sleep and at rest, usually following ingestion a large meal at night. Victims are in apparent good health prior to their demise. Current pathophysiological mechanisms of Brugada syndrome seem plausible explanations for the majority of this subset of Bangungot sons. Here is a summary of Philippine autopsy studies taken prior. Gross findings reveal mostly usual postmortem cardiac, pulmonary, visceral, and brain findings. Many disease entities, including acute pancreatitis, which is we always say it's pancreatitis, were included under the diagnosis of SUNS and Bangungot. The finding of acute pancreatitis is not generalized and consistent, it may just be concomitant. Or probably, the cause of Bangungot is likely the result of postmortem pancreatic change, which still remains unclear at this point in time. Many reports lack microscopic findings, and the unavailability of modern diagnostic techniques at the time rendered the diagnosis of SUNS inconclusive. However, most authors of these studies suspect a cardiopulmonary etiology. So here we have a diagnostic criteria for Bangungot SUNS for those who will be doing physical examination on applicants, males probably, for uniformed services. Clinical features: born in the Philippines, having Philippine ancestry, at least 2 years of age. History of being resuscitated from sudden cardiac death labeled as Bangungot by their treating physicians. Events takes place during sleep or at rest, and the victim is known to be healthy until immediately before the event. This may include at least one of the following: male sex, age 16 to 65, witness agonal respiration, moan, or difficulty in breathing, positivity or positive history of family members dying during sleep or sudden unexplained death at a young age. Exclusion criteria: we exclude evidence of another identifiable serious medical condition such as myocardial infarction, thyroid disease, infectious disease, severe thiamine deficiency, diabetes, electrolyte imbalance, and other diseases that may secondarily cause cardiac arrest. So for those who would go into the uniform services and do physical examination, you should take note of this, and your RBPB may not be as safe as we call it. You have to look after these guys. They might just die in their training. Conclusions, recommendations. Autopsy represents the first and last opportunity to make an accurate diagnosis in sudden cardiac death, which is true. Most of the time, we'll never find out what really happened. And in Bangungot, it's the only way that you'll be able to find out, or let's say the SUNS or the so-called Brugada syndrome. This autopsy will only be the one to make some sort of clear diagnosis at the end. Recommendations would be a method of investigation that should be updated, including not only for protocol for examination of the heart and histological sampling, but also for necessary for the toxicology, microbiology, biochemistry, and finally, molecular investigation of this case. Recommendations apply not only to university medical centers and regional hospitals, but to all professionals practicing pathology and forensic medicine. The establishment of regional multidisciplinary expert networks. They should include pathologists, cardiologists, geneticists, working in collaboration with microbiologists, toxicologists, and radiologists. The major purpose of this network is to improve the diagnosis of sudden cardiac death and to identify and organize preventive strategies for families in the setting of genetic abnormalities. This is the third of a case that I had to do in Africa, which has the so-called sudden unexplained nocturnal death. 2 are Africans and 1 is a German guy, all having heavy meals before going to bed and heavy drinking, and they died in their sleep. typical case. And it will probably more if we could just make investigations here in the Philippines and postmortems to be able to find out the real cause of death. These are my references in this presentation, and I would like to end my sector's report again with the same. Pathology is the foundation of medical science and practice. Without pathology, the practice of medicine will be reduced to myth and folklore. And with that, I thank you for this part of the program. Thank you and good morning.
Thank you, Dr. Ritualo, for the very interesting and comprehensive discussion of the case. We will now move on to the MCQ portion of this grand CPC.
Here are the participants for question number 1. Okay, they're all confirmed. Please send your answers privately to Dr. Nicolas through the Zoom chat, okay? Please send your answers privately to Dr. Nicolas through the Zoom chat. Be sure to indicate your team name and your answer. For example, your house Gryffindor and your answer is letter A. Put in the chat Gryffindor A. You understand? Okay. So, question number 1. Which of the following criteria is associated with acute pancreatitis? A. Duke's criteria. B. Stanford criteria. C. Jones criteria. D. Ranson's criteria. Timer starts now. Okay, time's up. The correct answer is letter D. Dr. Nicolas, who got the correct answer?
Ilvermorny and Muggles got the correct answer.
Okay, Ilvermorny and Muggles, congratulations. So after question number 1, Muggles and Ilvermorny both have 2 points. Thank you very much for participating. You may now leave the chat.
Doctor, for whom we have to send the answers?
Okay, please send your answers privately to Dr. Nicolas in the chat. You should see her there, Dr. Nicolas. All right, very good. Okay, so these are the participants for question number 2. From Janice, are they confirmed?
Yes, sir.
All right, so let's move on to question number 2. Which of the following is not part of Ranson's criteria at admission for patients more than 55 years old? A. Calcium less than 8 grams per day. AST greater than 250 IUs per liter. LDH greater than 350 IUs per liter. Glucose greater than 200 milligrams per deciliter. Timer starts now. Okay, time's up. The correct answer is letter A. Dr. Nicolas, who got the correct answer?
Durmstrang got the correct answer.
Okay, Durmstrang. Question number 2. Muggles, Ilvermorny, and Durmstrang all have a total of 2 points. So thank you. Thank you for joining. You may now leave the chat. So, here are the participants for question number 3. Janice, are they all confirmed?
Yes, sir.
Right. Please, instructions, please send your answers privately to Dr. Nicolas in the Zoom chat. So Dr. Nicolas should be in the Zoom chat. Send your answers privately to her. Be sure to indicate your team name in your answer. For example, your house Gryffindor and your answer is letter A. Your answer in the chat will be Gryffindor A. Do you understand? Alright. Question number 3. Which of the following is not associated with sick sinus syndrome? A. Blockage in the His-Purkinje system. B. Elderly patients. C. Failure of the sinus node to start the electrical wave. Or D. Very slow heart rate followed by arrhythmias. Timer starts now. Okay, time's up. The correct answer is letter A. Dr. Nicolas, who got the correct answer?
Ilvermorny, Muggles, and Voldemort got the correct answer.
Okay, Ilvermorny, Muggles, and Voldemort got the correct answer. So after question number 3, we have Muggles and Ilvermorny tied with 2 points each, and then Voldemort and Durmstrang again with 2 points each. Thank you very much for joining us. You may now leave the chat. Here are the participants for question number 4. Ma'am Janice, are they all confirmed?
Yes, sir, they are all verified.
Alright, instructions. Please send your answers privately to Dr. Nicolas through the Zoom chat. Be sure to indicate your team name and your answer. For example, you are House Gryffindor and your answer is letter A. Your answer in the chat will be Gryffindor A. Okay? Okay, good. Question number 4. Which of the following is indicative of a right bundle branch block? A. Left axis deviation to negative 60 degrees, widen QRS and small q in lead AVL. B. Tall R waves in V1, deep S waves in AVL, and tall P waves in V3. C. High voltages in leads V4, V5, and V6, as well as a prominent R wave in V1. Letter D. QRS duration of more than 0.12 seconds. Deep S waves in leads 1 and V6. In presence of rabbit ears in V1 to V2. Timer starts. Okay, time's up. The correct answer is letter D as in dog. Okay, Dr. Nicolas, who got the correct answer?
Durmstrang and Muggles got the correct answer.
Okay, Durmstrang and Muggles, congratulations. So after question number 4, Muggles is in the lead with 6 points, followed by Ilvermorny and Durmstrang with 2 points, finally Voldemort with 2 points. Okay, thank you very much. You may now leave the chat. Here are the participants for question number 5. Ma'am Janice, are they all confirmed?
Yes, Doc, they are all confirmed.
Right. So, instructions. Please send your answers privately to Dr. Nicolas through the Zoom chat. So, Dr. Nicolas is in the Zoom chat. Send your answers privately to her. Be sure to indicate your team name and your answer. For example, your house name is Gryffindor, and then your answer is letter A. So your answer in the chat will be Gryffindor A. Do you understand? Okay. Right. So question number 5. Which of the following is not a complication of acute pancreatitis? A. Phlegmon, B. Calcification, C. Pseudocyst, or D. Hemorrhage. Time starts now. Okay, time's up. The correct answer is letter B, as in boy. Okay, Dr. Nicolas, who got the correct answer?
No one got the correct answer.
No one got the correct answer. That's okay, guys. So, score stays the same after question number 5. Thank you very much, everyone. You may now leave the chat. So, here are the participants for question number 6. Ma'am Janice, are all of the students confirmed?
They are all verified, Doctor.
Okay. Instructions, please send your answers privately to Dr. Nicolas through the Zoom chat. All right. Be sure to indicate your team name and your answer. For example, your team, your house, Gryffindor, and your answer is letter A. So put in the chat to Dr. Nicolas, Gryffindor A. Do you understand? Okay. All right. So let's move on to question number 6. Which of the following enzymes is most specific for pancreatic diseases? Letter A, amylase. Letter B, lipase. Letter C, lactate dehydrogenase. Letter D, gamma glutamyl transferase. Timer starts now. Okay, time's up. The correct answer is letter B. Okay, Dr. Nicolas, who got the correct answer?
No one got the correct answer.
No one got the correct answer, unfortunately. Okay, so after question number 6, the score stays the same. Muggles with 6 points, Ilvermorny and Durmstrang with 4 points, Voldemort with 2 points. Thank you very much, everyone. You may now leave the chat. Here are the participants for question number 7. Ma'am Janice, are all of the students confirmed?
Doctor, they are all confirmed.
Very good. Instructions to you guys, please send your answers privately to Dr. Nicolas through the Zoom chat. Privately to Dr. Nicolas only, not to everyone, okay? Be sure to indicate your team name and your answer. For example, your house Gryffindor and your answer is letter A. Your answer in the chat will be Gryffindor A. Do you understand? All right, very good. So question number 7. Which of the following drugs is mainly used for acute methanol or ethylene glycol intoxication? A, benzodiazepines. B, fomepizole. C, acamprosate. Or D, naltrexone. Timer starts now.
Sir, to whom should we send the answer?
And through the chat to Dr. Nicolas. Okay, time's up. You got it. The correct answer is letter B. Dr. Nicolas, who got the correct answer?
No one got the correct answer.
No one got the correct answer, unfortunately. Okay, so after question number 7, this is still the score. Muggles with 6 points, Ilvermorny and Durmstrang with 4 points, and Voldemort with 2 points. Thank you for participating, everyone. You may now leave the chat. Here are the participants for question number 8. Ma'am Janice, are all of the students confirmed?
Yes, Doc, they are all confirmed.
Here are the instructions, alright? Please send your answers privately to Dr. Nicolas through the Zoom chat. Be sure not to send it to everyone, only to Dr. Nicolas, okay? Dr. Nicolas should be here in the list of participants. Be sure to indicate your team name and your answer. For example, your house Gryffindor. Your answer is letter A. Your answer in the chat will be Gryffindor A. If you're Muggles and your answer is B, put Muggles B. Okay, do you understand? Okay, all right. Question number 8. Buildup of which byproduct of alcohol metabolism is responsible for the flushing and nausea associated with metronidazole administration after consuming ethanol? Is it A, omeprazole, B, formaldehyde, C, acetaldehyde, or D, oxalic acid? Okay. Timer starts now. Time's up. Hopefully, we've said already your answers. The correct answer is letter C. Oh, letter C as in cat. Dr. Nicolas, who got the correct answer?
Voldemort and Ilvermorny got the correct answer.
Okay, Voldemort and Ilvermorny, congratulations. So, Muggles and Ilvermorny now tied for first place with 6 points. Voldemort and Durmstrang close behind with 4 points each. So, thank you everyone for participating. You may now leave the chat. So, here are the participants for question number 9. Ma'am Janice, are all of the students confirmed?
Yes, Doc, they are all confirmed.
Right? Instructions to you guys. Please send your answers privately to Dr. Nicolas through the Zoom chat. Dr. Nicolas is among our participants today. Send the message privately to her, not to everyone, okay? Just privately to her. Be sure to indicate your team name and your answer. For example, your house Gryffindor and your answer is letter A, your answer in the chat will be Gryffindor A. If your team Ilvermorny and your answer is letter D, put Ilvermorny D. Do you understand? Yes? Okay. Alright. Here is question number 9. Which of the following is not a systemic complication of acute pancreatitis? A. Shock. B. Kidney failure. C. Phlegmon. D. DIC. Timer starts now. Right, time's up. Here are the participants for the last question. Ma'am Janice, are all of the students confirmed?
Yes, Doc, they are all verified.
Okay, very good. Okay, instructions to all of you. Please send your answers privately to Dr. Nicolas through the Zoom chat. So in the participants, Dr. Nicolas is there. Send your answer only to her, not to everyone, because everyone will be able to see your answers. Okay? So just privately to Dr. Nicolas through the Zoom chat. Be sure to indicate your team name and your answer. So if you're Muggles and your answer is letter A, put in your answer Muggles A. If you're Voldemort and your answer is B, put Voldemort B. Do you understand? Yeah? Okay. So send all of your answers only to Dr. Nicolas. Alright? So here is the final question for the MCQ portion. Brugada syndrome is a disorder characterized by the following except A. Incomplete right bundle branch block. B. ST elevations in the anterior precordial lead. C. Sudden death. D. Complete left bundle branch block. Timer starts now. Okay, time's up. The correct answer for question number 10 is letter... Oh wait, not yet. What's the correct answer? Dr. Romba, what's the correct answer for question number 10? The correct answer is letter D. Okay. Dr. Nicolas, who got the correct answer?
Ilvermorny, Muggles, and Voldemort got the correct answer.
Okay, Ilvermorny, Muggles, and Voldemort got the correct answer. All right. So, the final score for the MCQ portion, Muggles with 10 points. Congratulations. Ilvermorny and Voldemort each with 8 points each. And finally, Durmstrang with 4 points. Thank you very much for joining the MCQ portion. You may now all leave the chat.
At this point, we would like to thank each and everyone to the President of the University, Mr. Anthony Jose M. Tamayo, our School Director, Dr. Arnaldo de Guzman, our Dean, Dr. Emelita Gatmaitan, Board of Judges, faculty members, mentors, and students. This has been a successful and triumphant activity of the department. Congratulations to all for the efforts extended, most especially to the winner. This has been your host, yours truly, Dr. Zita de la Merced, together with Dr. Rodelia Nicolas. Before we end this program, a closing remarks will be given by Dr. Emelita Gatmaitan, Dean of the JONELTA Foundation School of Medicine, to be followed by awarding of winners by Dr. Silveriano Witwalo III, Chair of the Department of Pathology.
To the members of the faculty staff, especially the Department of Pathology, judges, students, and friends. Once again, we have reached the culmination of our virtual Clinical Pathology Conference. And as the years pass, we have witnessed how our students have honed their skills at trying to dissect a pathology case, going through the history and physical examination, determining and discussing the possible illness of the patient, and finally coming up with a final diagnosis. I wish to congratulate the Department of Pathology for this intellectual exercise. They have patiently and persistently strived to make the presentations better and better. Congratulations too to the faculty advisors for preparing the participants in hurdling this learning experience. We wish to express our gratitude to all the judges for also sharing their expertise and precious time. Congratulations to the winners and to all the participants. Remember, the essence of this activity is not in the winning, but in developing your skills to be a better, if not the best, physician. May this activity continue on and inspire our students to do better and become a globally competitive physician in the future. Thank you and good morning.
We come now to the most important part of the Grand CPC, the declaration of the second part winner and the overall champion for the 4th Annual Grand CPC March Customized Batch 2020. This is how they scored. We have 4 houses: Muggles, Ivelmori, Voldemort, and Doomstrong. And they are judged by the following judges: Dr. Ruiz, Dr. Lim, Dr. Nang, and Dr. Kaidi. In the following categories: graphics and video content, presentation skills, mastery of the case, the ability to answer their specific judges, and we have an MCQ question from which we are 10 selected students supposed to answer 10 questions for a total of 20 points. All of these are added up to get their scores, and this is how they scored. For graphics and content, Muggles got 17.5, Ivelmori got 16.5, Voldemort got 16.61, Doomstrong got 16. In this category, Muggles was the highest at 17.5. For presentation skills, Muggles at 16.25, Abelmori at 15.5, Voldemort at 15.72, and Doomstrang at 15.75. The highest again in this category representation skills is Muggles. For Master of the Case, Muggles got 16.25, Abelmori got 15, Voldemort got 15.22, and Doomstrang got 16. In this Master of the Case, it is again Muggles, highest at 16.25. In the ability to answer the specific judges, Muggles got 17, Abelmore got a near perfect 19, Voldemort got 10, and Doomstrang got. So the highest in this category is Abelmori at 19. MCQ question answered by 10 select students. Muggles got 10 out of 20, Abelmori got 8 out of 20, Voldemort got 8 out of 20, and Doomstrang got 4 out of 20. The total for each of the houses is 77 for Muggles. Abelmori got 74, Voldemort got 65.56, and Doomstrang got 66.75. So the winner for the second part of the fourth Grand CPC is Muggles at 77, and they are presented by the following presenters: Sabu Nagma, Syed Sabihi Alam Sahan, Singh Saloni, Wahid Shuham Janglio, and Yogarasha Ritesh Ghosh. And they are judged by Dr. Angelica Marie Soria Kainde. So, congratulations to Muggles, the winner of the second part, fourth Grand Annual CPC customized with an average score of 77%. And they are mentored by Dr. Dinaresad Miranda from Pathology, Dr. Jennifer Yasser Mateo from Pathology, and their clinical mentor is Dr. Katrina Ann Balmores from Otolaryngology. So we take the scores from the first CPC and we add that to the second CPC, and the average will now come up with the overall champion for the fourth annual Grand CPC. So this is how it came out. For Muggles, they got a score of 69.25 in the first CPC. Abelmori got 72.5, Voldemort got 75.5, and Doomstrang got 78.5, in which in the first CPC, Doomstrang was declared the winner for the first CPC. In the second CPC, Muggles got 77, Abelmori got 74, Voldemort got 65.56, and Doomstrang got 66.75. In the second CPC, it was Muggles who was declared the winner. So we sum up both of this and we get the average from each. So the average for Muggles for both CPC is 73.13, Abelmori got 73.25, Voldemort got 70.53, and Doomstrang got 72.63. So in the overall champion in this case is 73.25 by Abelmori, who won by a mere 0.12%, 0.12 over Muggles to become overall champion. And they are represented by the following. You have Yakub Predi Philip, Yada Pranali Nituti, Karim Rajimat Olorum Sinwala, Lawrence Jevajiri Jihad Rani Lexi, and Maharatpa Subra Yurab, and they are judged by Dr. Sarah Jane Datayli. Congratulations to Abelmori, the overall champion of the fourth annual Grand CPC with an average score of 73.25, and they are mentored by the following: Dr. Ifitasar Haron from Pathology, Dr. Dean Jean Sope from Pathology, and Dr. Ethel Pineda Garcia from Internal Med. We would like to again congratulate all of the other presenters for a job well done, and to Abelmori for being the overall Grand Champion. Thank you. Finally, we come to a close another chapter, in the Department of Pathology online clinical pathological conferences. My congratulations to the winners of the first and second CPC, the houses of Doomstrong and Muggles respectively. Congratulations to the house of Ivalmori, who unexpectedly got enough points to get the highest average score for both CPCs and was declared overall champion for the 4th Annual Grand CPC March Customized Batch 2021. An outstanding performance. It is the first time a non-semestral winner becomes the overall champion based on average points. Our warmest thanks to the clinical and pathological mentors for their guidance and patience. Profound gratitude to the judges for their time and effort. To President Anthony Tamayo, Dr. Arnaldo de Guzman, our school director, thank you for having faith that we could adapt and be able to present an online CPC during this pandemic. To our Dean, Dr. Emilita Gatmaitan, Secretary, Dr. Alma Ramirez, Dr. Wendy Nicanor and Dr. Arca, coordinators for the regular and customized classes respectively, thank you for your unwavering support. To the CPC Organizing Committee chaired by Dr. Umbao, with members Dr. Tawasil, Dr. Olveda, Dr. Nicolas, and Dr. De La Merced, congratulations for a job well done. So with this clinical pathological conference, we are now closing the Harry Potter team, which is in its 5th year. To the houses of Slytherin, Hufflepuff, Ravenclaw, Gryffindor of the September regular and customized batches, to the houses of Voldemort, Ivalmori, Doomstrong, Muggles of the March customized batch, thank you for the memorable moments that you have given. The next CPC will be contested by members of the September regular and customized batches, which is tentatively scheduled for February of 2022. Our theme for next year will be the futuristic Star Wars Legacy. We hope to see you again in February of 2022 for the next online CPC. And with this, I now would like to give my last hex for the Harry Potter team. Protego Totalum.